Welcome back, students. Let's continue with the beta blockers. Let's see the features of the cardioselective beta blockers. In the previous video, we saw the classification of beta blockers, non-selective, cardioselective. So, what are cardioselective beta blockers? They are beta 1 selective beta blockers. Which receptor is present mainly in the heart? Beta 1 is predominantly present in the heart. So, when beta 1 receptors in the heart are primarily blocked, they are called as cardioselective beta blockers. Let's see what are the features of cardioselective beta blockers. They have low propensity to cause bronchoconstriction. So, beta 2 receptors are present in the bronchial smooth muscle, which can, if you block that, there will be bronchoconstriction. So, because beta 2 receptors are not blocked, only the beta 1 receptor is blocked. That is why there is lower propensity to cause bronchoconstriction. There is less interference with carbohydrate metabolism. Glycogenolysis is not inhibited, so they are safer to be used in diabetes patients. There is lower incidence of cold hands and feet. They have less deleterious effect on the lipid profile, and they are less likely to impair astrocyte capacity. All these features are because they primarily block only the beta 1 receptor without much action on the beta 2 receptors. But disadvantage of cardioselective beta blockers, they are ineffective in controlling tremors. When we were discussing classification, we saw beta blockers, non-selective beta blockers. Again, two subtypes were there: beta blockers with intrinsic sympathomimetic action and beta blockers without intrinsic sympathomimetic action. What are drugs or beta blockers with intrinsic sympathomimetic action? So, beta blockers, they have antagonistic property, blocking property on the beta receptors. But these drugs, that is beta blockers with intrinsic sympathomimetic action, they also have some amount of agonistic action on beta 1 and beta 2 receptors submaximally. So they are somewhat like a partial agonistic action they have. They are not completely antagonist and not completely agonist. Okay, so they have agonistic action submaximally. So the drugs are Pindalol and Celiprolol. These are the beta blockers with intrinsic sympathomimetic action. Let's see what are the features of these intrinsic sympathomimetic action beta blockers. So they have less propensity to cause bradycardia and myocardial depression. Rebound hypertension after withdrawal is less likely because they are not completely blocking the receptors. So rebound hypertension happens because the receptors become supersensitive, right? So that is very likely unlikely. Lipid profile is less worsened, but they have disadvantages. They are not effective in migraine and they are not suitable for secondary prophylaxis of MI. Coming to the therapeutic uses of beta blockers. So first uses in hypertension, essential hypertension. Okay. So they are considered to be a first choice drug because of good patient acceptability and also cardioprotective potential. So they can be used alone or in combination with diuretics or any other first line antihypertensive drugs. And the fall in BP is gradual and it does not produce postural hypotension, unlike alpha blockers. They are mainly used in mild to moderate hypertension, essential hypertension. Another indication is in myocardial infarction. Okay. Beta blockers are used for two purposes. One is for secondary prophylaxis of MI, and second is during the evolution of MI. So, in secondary prophylaxis of MI, it can prevent the reinfarction. The studies have shown that long-term use after recovery from MI has been found to decrease the subsequent mortality. And during evolution of MI, beta blockers can limit the infarct size by reducing the oxygen consumption. They can produce redistribution of myocardial blood flow and they also have antiarrhythmic action. So in myocardial infarction, the drug of choice is usually a pure beta 1 antagonist. Next is in angina pectoris. So angina pectoris, angina of effort, a classical angina, it's very much useful. So usually chronic prophylactic treatment will be required in classical angina or angina pectoris. So long-term treatment can reduce the frequency of attack and also can increase the exercise tolerance, but they are not suitable for variant angina. Okay, because this unopposed alpha-mediated coronary constriction can happen. That is why they are not useful for variant angina. Only in classical angina, beta blockers should be used. Beta blockers are usually seen to worsen the heart failure, but studies have shown that cardioselective beta blockers like metoprolol, bisoprolol, nebivolol, carvedilol actually can improve the patient with heart failure. So ventricular function usually depends on increased contractility, which can be due to sympathetic overactivity. So beta blockers can prevent this homeostatic response and introduced gradually with beta blocker, and if it is maintained for for a long period of time, they can retard the progression and prolong life. So the benefit usually results from antagonizing all the damaging effects of cardiac beta 1 receptor overactivity, mainly beneficial in patients with mild to moderate heart failure. In cardiac arrhythmias, especially esmolol and propranolol are used. So these drugs are seen to suppress extrasystoles and tachycardias, which are actually usually mediated adrenergically. They are effective in all supraventricular tachycardias, and the beneficial effect is seen due to increasing the refractory period of the AV node and direct membrane stabilizing action. In aortic dissection. So aortic dissection occurs when there is a tear in the inside of the aorta, causing the blood to flow between the layers of the walls of the aorta, forcing the layers apart. So beta blockers, it can be initiated to reduce the cardiac contractility. So usually you give drugs with negative inotropic effects like beta blockers or calcium channel blockers can be used if beta blockers are contraindicated. So usually beta blockers like levodopa, propranolol or esmolol can be given intravenously or orally. IV nitroprusside drip can also be given. So levodopa, when it's given IV, it has a dual effect of decreasing the blood pressure and also the cardiac contractility. If beta blocker cannot be used, you can always go for calcium channel blockers. Other uses, they can be used in esophageal variceal bleeding and hepatic portal hypertension. So usually propranolol and nadolol can be used in this condition where it can reduce the cardiac output and also induce splanchnic vasoconstriction. In hyperthyroidism, so in patients with hyperthyroidism, there will be symptoms of sympathetic overactivity. So beta blockers, when given, can reduce the unpleasant symptoms of sympathetic overactivity like tremors, palpitation, sweating, etc. So propranolol mainly inhibit the conversion from T4 to T3. Next is the pheochromocytoma. So pheochromocytoma, as we discussed earlier, it's a tumor in the adrenal medulla where there is increased or excess release of catecholamines. So alpha blockers combined with beta blockers can be helpful in pheochromocytoma to control tachycardia and arrhythmia. Propranolol or any other beta blocker should not be used alone. Should be always Propranolol should be always combined with alpha blockers in pheochromocytoma. Next is in anxiety provoking situations. Usually propranolol is used. So they are very much beneficial under conditions which provoke nervousness and panic. They have anti-anxiety effect. And they also block the peripheral manifestations of anxiety like palpitations, tremor, and sweating. But they are not effective in anxiety neurosis or generalized psychological disorders. They are very much useful in migraine. Propranolol, it is effective for prophylaxis, which can reduce frequency and severity of attack. So if given, propranolol is given, the effect can be seen in 4 weeks. The mechanism of action is not very clear. You can start with 40 milligram of propranolol in migraine. Next is in alcohol withdrawal. So alcohol withdrawal, beta blockers like propranolol can reduce the central sympathetic overactivity and can be beneficial in alcohol withdrawal symptoms. Next is glaucoma. So in glaucoma, by reducing the aqueous humor. So beta 2 receptors are present in the ciliary epithelium. So blockade of beta 2 receptors in ciliary epithelium, there is reduced aqueous humor, which can reduce the intraocular pressure and they can be beneficial in glaucoma. So you can use drugs like timolol, betaxolol, nebivolol. These are the other topical betaxolol, nebivolol are topical beta blockers which are applied into the eye as eye drops in glaucoma. In hypertrophic obstructive cardiomyopathy, so the subaortic region is usually hypertrophic and forceful contraction of this region under sympathetic stimulation, which could be exercise or any motion, can increase the outflow resistance, which has incapacitating hemodynamic consequences. So beta blockers can improve the cardiac output in such patients and very much beneficial during exercise by reducing the left ventricular outflow obstruction. Okay, but they do not have much action while at rest. Coming to the individual drugs, beta blockers. So you have sotalol, which is a which has additional cardiac rectifier potassium channel blocking property, and it's a class 3 antiarrhythmic drug. Timolol is a drug which can be very beneficial in glaucoma. It can be used as a topical agent in glaucoma, and systemically it can be used in hypertension, angina, prophylaxis of MI. So these are the other drugs, betaxolol, levodopa, carvedilol, and metoprolol, which are other topical beta blockers useful only in glaucoma. Pindolol is a drug which is mainly useful in hypertension. Metoprolol can be used in hypertension and congestive cardiac failure. Bisoprolol usually given as a once daily administration in angina, hypertension, and cardiac failure, congestive heart failure. Atenolol is a cardioselective beta blocker mainly useful in hypertension and angina pectoris. Esmolol is an ultra short acting beta blocker. Is very beneficial in SVT, episodic arterial fibrillation, flutter, and arrhythmia. Nebivolol, they have NO, nitric oxide donor activity, which produces vasodilation, which can improve the endothelial function and delay atherosclerosis. So they are mainly used in hypertension and congestive heart failure. Another drug is celiprolol, which has weak beta-2 agonistic activity, like uh, the drugs we discussed previously, with drugs with beta blockers with intrinsic sympathomimetic activity, which can decrease the vascular resistance, and they are found to be safe in asthmaticus, so very much useful in hypertension. With lebetalol is a beta blocker with additional action, that is, it's a beta blocker with alpha blocking property. Okay, so it is more potent in blocking the beta receptors than the alpha receptors. Even though they have both blocking action, they have more potency in blocking the beta receptors, and relatively high doses can reduce the cardiac output and total peripheral resistance. So low dose the effect resembles those of propranolol alone. While high dose, they are like a combination of propranolol and an alpha blocker like prazosin. Okay, so they are considered to be a moderately potent hypotensive uh, drug. So in contrast to propranolol, the lymph blood flow is increased with labetalol. It is also shown to inhibit noradrenaline uptake by the adrenergic nerve ending. So adverse effects commonly seen is postural hypertension, failure of ejaculation, and other side effects of alpha blocking property can also occur, but plasma lipid profile is not altered. So their main indication is pheochromocytoma, clonal withdrawal, and hypertension. Next beta blocker with additional action is carvedilol. Again, they have alpha blocking property also. So they can block the alpha 1 receptor, beta 1 receptor, and beta 2 receptor. So they can produce vasodilation by action or blocking the alpha receptors and also by calcium channel blockade. They also have additional antioxidant property and they are considered to be cardioprotective in patients with congestive heart failure and essential hypertension. With that, we come to the end of beta blockers. Thank you for your patient listening.